Hello, everyone, and welcome to today's webinar on COVID-19 and thalassemia. My name is Craig Butler, and I am the National Executive Director for the Cooley's Anemia Foundation, and I am very happy to welcome you to this very special webinar. I would like to acknowledge that this work is supported by a sub-award agreement through the Association of University Centers on Disabilities and their cooperative agreement number NU 380T000280, funded by the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of AUCD or CDC. Before I introduce our guest presenters, I'd like to go over a few points for housekeeping points about joining the webinar. So now that you've joined the webinar, you have two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If you choose the phone option, the webinar toolbar will provide you with the phone and access number and audio pin. Now, all audio will be muted during the webinar. We have two presentations, and at the end of the second presentation, there will be time for questions for both of our speakers. So to submit a written question, which some people are already doing, it looks like, please use the questions area of your toolbar. You submit your questions in the questions area at any time, and we'll respond to as many as time allows during the Q&A session at the end. While we would like to be able to answer every question, if a question is very specifically about issues involving one particular person, we may not be able to address it because it may require more knowledge of that person's background than we have. Today's webinar will last approximately 1 hour, and it will be recorded, so it will be accessible afterwards. And we're going to start today's webinar with a few short questions for those of you watching. The first two questions are really just to learn a little bit about who is watching the webinar today. So let's get to the first question. So please answer this to the best of your ability. Which of the following best describes you, an individual with thalassemia other than thalassemia trait, a family member of an individual with thalassemia, a healthcare provider, a pharma representative, or other? And we'll take about 15 more seconds for people to select their answer. Okay, let's, Cheyenne, let's see the results for this question. Okay, 63%, we're mostly individuals with thalassemia or family members. Excellent. Let's go to the next question. So, whoops. Okay, is the question up, Cheyenne? I can't see it on my end if it is.
I apologize, Craig. That question was closed.
I'm sorry, I couldn't quite hear you.
I apologize, Craig. That question was closed right after it was launched.
Okay, that's fine. It's not a major issue. Let's move on to the third question. So we're going through a set of questions now that are going to be a little bit harder to answer. And I just want to say, don't worry about whether you get this right or not. Just answer it to the best of your ability. And also the next few questions, we're going to ask them again at the end of the seminar and see if there's any change in the answers, see if we've done a good job of getting information across. So which of the following is true regarding influenza and COVID-19 is our first question. We'll take about 15 more seconds to let people pick an answer. And again, don't worry about it. Okay, and we're not going to show you the results right now. We'll show results after we ask these at the end. So let's close this question and go to the next question. What's the most effective personal health measure that can be taken to prevent COVID-19? Again, answer this just to the best of your ability. Whatever you think is the most likely answer. We'll take about 15 more seconds or so. And let's close this question and go to the next one. Which of the following is true about COVID-19 and thalassemia? We'll spend about 20 more seconds letting people answer this question. Just a few more seconds to get your answers in if you have not done so already. And let's close this question and move on to the next. Individuals who get blood transfusions are at higher risk for COVID-19 because it is transmitted through blood. True or false? So we'll take about 15 seconds for people to make their choice here. Just a few more seconds. And we'll close this question and move to the last one on this round. It is okay to travel this holiday season, true or false? Again, we'll take about 20 seconds to let people make their choice. Just a few more seconds to answer this one, and then we'll move on. Okay, we'll close this question. And as I said, after we finish our presentations, we'll come back and ask these questions again and see if everyone has the same question or different ones. So now it is my pleasure to introduce our first presenter, Dr. Priya Nori, who will be talking about COVID-19 in general. Dr. Nori is an associate professor of medicine and orthopedic surgery at the Albert Einstein College of Medicine. She serves as medical director of the Antimicrobial Stewardship Program and outpatient parenteral antibiotic therapy program at Montefiore Health System, and is program director of the Infectious Diseases Fellowship Program. She is an alumna of the Johns Hopkins University and Albert Einstein College of Medicine, where she received the American Medical Women's Association's Glasgow Rubin Achievement Award and was inducted into the Alpha Omega Alpha Honor Society. She completed her internship at Baylor College of Medicine, residency at the New York-Presbyterian Hospital, Weill, Cornell. She returned to Einstein Montefiore for fellowship in infectious diseases, then stayed on as faculty 2013 onwards. She oversees stewardship operations at the Bronx campuses and ambulatory sites. She also serves as medical director of the Montefiore OPAT program, an innovative ID care management program led by the Montefiore CMO. Dr. Nori, welcome, and let's begin.
Craig, thank you so much, and thanks to the Cooley's Anemia Foundation for this wonderful invitation to speak and share what I know about the disease, and also recommendations and tips from my personal experiences. Okay. All right, perhaps maybe you can advance the slides for me. I'm not able to get control here. Okay, there we go. Maybe just a little lag. Okay, so we should start with some basics just to make sure that we understand the fundamentals about the virus, and that'll help us to build on that knowledge base and truly understand how the virus spreads and how it affects individuals and how it spreads between people. So coronaviruses they're not actually as exotic or new as they may seem right now. Coronaviruses have been around for probably, millions of years. They've infected humans as long as human beings have been alive. There's hundreds to thousands of them. The ones that cause infections in humans most frequently cause things like the common cold. So these are things that children get and pass to adults, but for the most part, they don't cause significant disease. They don't cause illness that is so bad that it shuts down society or causes major outbreaks. These are, for the most part, the common cold. However, once in, let's say, every generation or so, there is a subset of coronaviruses that causes a lot of damage and causes a global pandemic. So the best example in recent history besides COVID-19 is SARS-1. So you may remember from the early 2000s, late 1990s, that there was a virus that also originated in China, caused a severe respiratory illness and spread throughout the world, but actually did a lot less damage than the current coronavirus, which is SARS-CoV-2. So SARS-CoV-2 is the virus, and the disease that it causes is COVID-19. That is an important distinction because the test for the disease tests for the SARS-CoV-2 virus and not necessarily COVID-19. So just keep that in mind, because when you get your test reports and things, they may not say COVID-19, but they will say SARS-CoV-2. So the primary mode of spread between individuals in offices and schools and in households mainly is from one infected person to someone else, to a vulnerable person. And so this disease is spread for the most part by people coughing, sneezing, laughing, talking, singing, all of these activities that involve propelling droplets, respiratory droplets that are carrying the virus from one infected person to another nearby person or several persons. One thing that we've learned after all this time studying this disease and treating people with this disease is that this is predominantly the thing to worry about in terms of spread from person to person. While the virus can settle on surfaces and contaminate surfaces and live on surfaces for hours up to days in some studies, it's not really that important. It's not a major concern in terms of spreading the virus around. I'll tell you something that has infected millions of people around the world. It's not because their cell phones are infected or their surfaces or their pens or their purses. To be really efficient and as lethal as it can be and as quick in infecting so many people in a single setting, it really is not something that's going to jump from surface to surface, but rather it's something that's spread from one person to another, mainly by coughing and other use of the airway. Okay, so what happens is people then also might touch their own secretions and then spread it around their own bodies, their own faces, and then maybe even touch their children or household contacts. And so all of these things come into play, but really it's the respiratory spread that is most important. So the symptoms that everyone should keep in mind that you may be very well familiar with by now, hearing about this disease for months and months, these are the symptoms that are most important to keep in mind. So about 10 to 20% of the population may be asymptomatic or pre-symptomatic. However, those who develop symptoms, it's usually something like, it starts with a severe headache and severe body aches and tiredness. And then sometime within a few hours, people will start to get fevers and chills. And then within a few days might start to get a sore throat and cough. It's usually a dry cough. It's not one of these wet coughs that produces a lot of phlegm. So those are symptoms that are pretty typical for a lot of viruses, especially something else like influenza, which we'll talk about soon. But a couple of symptoms are very unique to COVID-19. And these are the loss of taste and smell. There seems to be some impact on the nerve cells that affect the brain and that have receptors in your nose and mouth that contribute to the loss of taste and smell. And this is very unusual. I mean, virtually no other virus that I can think of does something like this. So that's an important distinction between something like the flu or other cold viruses and SARS-CoV-2 or COVID-19. Everything else on this list sounds just like influenza, doesn't it? If a loved one or if you should develop one of these symptoms or a cluster of these symptoms, how do you know whether or not it's time to go to the hospital, to the emergency department, or call 911? Well, if you're one of these individuals who, because of your underlying medical conditions, is at higher risk, you should have a lower threshold to visit the emergency department and potentially check yourself into the hospital, because you need to be monitored for some of these outcomes that are a little bit scarier, like your oxygen level dropping, having pneumonia on both sides of your lung on the x-ray. How do you know what that looks like? Well, patients with severe disease more often report a severe heaviness in their chest, trouble getting air deep into their lungs, a profound shortness of breath. Because of the drop in their oxygen levels, a couple of things happen. They may turn bluish. Their fingers and their lips may turn bluish. They appear very sleepy. They can't stay awake. And in some cases, they may also become confused. Okay, so the disease course since it arrived in the United States has been kind of what we call phasic. So it's had ups and downs. Here in the early part of 2020, so late winter from about February to, let's say, end of April, this is where the tri-state area, New York City, New Jersey, Connecticut, Boston, this is where we had our initial first wave. This period of time accounts for the rest of the country, so the Deep South, the Midwest, and some of, during this period of time, while much of the country was experiencing their first wave, let's say, the Northeast was starting to get flat because it was the summertime, people were outside, the spread of the virus was less, school was off, all of these things. And then here we are with the rest of the country. At this point in time, from about Labor Day onward, the country is all moving together, but in the wrong direction. There's very few states, there's very few pockets that are actually going in the right track. But for the most part, the entire country is moving towards this very scary place where there's like hundreds of thousands of new cases a day. And as the case numbers start to go up, the hospitalizations, the deaths, and all of those things go up accordingly. Okay, so let's talk about who gets really sick with the disease, okay? But first, let's make the distinction between those who are at risk for severe illness and those who get sick. So people who get sick because something happened. They may not necessarily use their masks properly. They may not use them all the time. They may not believe in them whatsoever. They may flout certain public health recommendations like not going to parties or large gatherings, indoor dining, certain settings like gyms, and you know all of the things that basically the CDC and public health officials are telling us not to do. Certain people just flout those things, but those are the same people who are young and they're healthy, or they feel indestructible. They don't feel like they have the medical risk to change their behavior. So those are the ones who, in my opinion, initially get sick, and then unfortunately, because of the choices they make, they bring it home to household contacts who may be a little bit more infirm. They are the people that are on this list with certain high-risk conditions that have clearly been shown to be linked with worse disease, more critical illness, more hospitalizations, and then more death. So as you can imagine, people with cancer, with advanced heart and lung disease, severe obesity, unfortunately pregnant women, patients with sickle cell disease and type 2 diabetes. We know that all of these individuals have worse disease. It's been proven time and again. This also includes people with organ transplants. However, who might get severe disease? This is less clear. There's certain groups of people that have some medical conditions. They're not without any chronic medical issues, but the data on whether or not they do worse once they are infected with COVID, with SARS-CoV-2 is less clear. And so on this list includes people with, let's say, controlled HIV, who are on medications and who are undetected in their viral loads, people who are overweight but not necessarily obese, and for the purposes of today, people with blood disorders like thalassemia. So there is certainly an increased risk, but it's not clear if that increased risk necessarily means that individuals with these conditions are hospitalized more or unfortunately succumb or die from the illness more frequently than others. Okay, so let's talk about how the infection goes from a respiratory droplet with the virus suspended into someone's nose or mouth and then into the rest of their body. Okay, so if I'm the sick individual and I may not realize, or I may go out into society knowing that I'm sick without a mask, I will talk to people, I will cough, I will maybe sneeze, I will sing. I don't really have a good voice, but let's say any of these activities can propel respiratory droplets that are infected with the virus, and those can land and settle in other people's noses, mouths, eyes, and then basically go into their bodies. So it starts off in people's upper airway, slowly makes its way down to the lungs, and then in the lungs, it creates a profound damage. So all of these cells along the way that are infected, well, the virus hijacks these cells to use the cell's enzymes in various compartments to make lots and lots of copies of itself. Once the virus has, let's say, hundreds of copies inside one cell, it makes that cell essentially burst open, die, and send all these little tiny particles of new viruses into that person's other tissues and other organs, and causes even more damage. So this cycle of infection and then inflammation and damage is just perpetual until either the person gets better or unfortunately succumbs to the disease. Okay, so what we're looking at here is a very close-up image of lung cells, which are infected with millions of these particles of virus. And so when these normal human cells die off, unfortunately, there's a profound immune response. There's a profound inflammatory response, which sometimes does more harm than good. And the virus may clear after a certain number of days. It may not be present in the system anymore, but the virus is like a ninja. It set off a cascade of all this damage in multiple parts of the body that lead to those really bad outcomes we talked about. So lung failure, heart failure, stroke sometimes, and lots of bad stuff. So this virus, the virus causing COVID, can infect really any tissue in the body, any organ system. Okay, so let's talk for a second about influenza versus COVID. Lots of people have questions about this because it's sort of a scary prospect to think that two of these pandemics can be going on at the same time. There are a lot of similarities in terms of how these things present, but a few important differences that can help us to distinguish. So we spoke about this a little bit before, but the main symptoms are pretty much shared between both. Fevers for several days, profound headache, dry cough, shortness of breath, feeling really, really run down, sometimes GI upset, diarrhea, but this loss of taste and smell is very unique to COVID-19, okay? Lots of people with COVID, as we said, can be walking around asymptomatic, meaning they don't even know that they're speaking and spewing the virus or singing and spewing the virus to their loved ones. But that's unusual for the influenza. Influenza hits hard. Most people who get exposed to it and it enters their body usually present with symptoms. I've never really heard about asymptomatic cases of the flu. You kind of know when you have it. But another very tricky aspect of COVID-19 is that 1 in 5 cases can be walking around asymptomatic, taking out a bunch of people around them in these super spreader events, and making it so hard for public health officials to get a hold of this virus and really contain it. Another very unusual feature of COVID-19 is that it is linked with blood clots. And this is because the virus can infect anywhere. One of the places it likes is blood vessels. It can cause clots in arteries. It can cause clots in veins, DVTs, can cause strokes. And we've seen a lot of damage happen because of the propensity or the fondness that the virus has for blood vessels. Both are very highly infectious. So one infected individual, if they don't isolate themselves from everyone else, will go on to infect at least one other person with influenza. But with in the case of COVID-19, again, the virus being SARS-2, one infected individual will go on to infect at least 2 other individuals, okay? So if you think about a family of 4, if one individual, or a family of 5, let's say, one individual gets it, they can go on to infect, let's say, both of the children in the family, the spouse, the grandmother that takes care of the kids. And this is why it's been so dangerous and so difficult to contain. Vaccine for COVID-19 is on its way, and it seems that the efficacy, or how well it works at preventing the illness in people that were vaccinated, is 90% or more in the 2 viruses that currently are almost on the market. Influenza tends to happen predictably in the winter months. COVID-19 has no preference for season, as we are seeing, but the caveat to that is that with the winter coming now to the Northeast and other places of the country, we're seeing more cases because people are hunkering down indoors and they're spreading the virus to each other rather than being in wide open spaces outdoors. They're both very dangerous, but the toll of COVID-19 ultimately would have been more in 2020, 2021 perhaps, but if you consider that influenza has been around for hundreds to thousands of years, many more people ultimately would have died from influenza than from COVID-19. Okay, so what can we do? What can we do to really curtail the spread or stop it in its tracks, prevent ourselves and our family members from getting sick? These things are very low budget. They're very low stakes and high reward, and they're probably as good as the vaccine is going to be. So number 1 is masks, and I cannot emphasize that enough. Wearing a mask properly over your nose, squeezing it down over your nose, and then making sure it comes underneath your chin and that it's a pretty close fit is the absolute best thing you can do. Cloth masks, surgical masks, all kinds of masks that cover this area are all very good, okay? Wearing it so your nose is exposed or your mouth is exposed, that's only half as good as it can possibly be. If you're gonna do it, you may as well do it right. In addition to mask wearing, hand hygiene, or washing your hands with soap and water, using alcohol-based wipes or alcohol-based rubs very frequently. You know, as whenever you leave your house and you might touch different surfaces, you touch your car, you hand your keys to the valet guy, you swipe your subway card, you have to be mindful of all these times that you touch something and train yourself to sanitize your hands after those events, okay? 6 feet of social distancing is also very important. I would say that that's probably, for me, maybe number 2 on the list of the best things you can do, with mask wearing being number 1. The 6 feet of distance is because, on average, the droplets that we keep talking about, those travel about 6 feet. Sometimes less, depending on how the ambient moisture and the wind and all of these conditions. Sometimes actually a lot more, but for the most part, it's an average of about 6 feet. 6 feet is not always possible, though. And there are situations where you're in line at the grocery store, you're in the doctor's waiting room and it's starting to get very packed. You're on the subway. You are, any number of public places that you really don't have control over. 6 feet is ideal, but it's not always possible. And that's where the mask comes in, okay? Because the mask is so effective, especially when worn by the person who's speaking and the person who is being spoken to. It's more than 90% effective if both people are doing that and doing it properly. So I'll give you an example where we've had many situations in the hospital where either a patient had COVID-19 or a healthcare worker had COVID-19. And that healthcare worker was around other healthcare workers all day long, very close together, in the same room, rounding, going to see all these patients. But because everyone was wearing their mask, nobody else got infected. And that proves how effective masks are. And at the end of the day, if everybody wears their mask, if there's a mask mandate, that will probably be the single most effective thing until the vaccine to bring this virus under control. So I would go with number 1, mask. Number 2, social distance. And then number 2.5, maybe hand washing. Okay. All right. How do we disinfect our homes? How do we make sure that our household surfaces are clean, our cars, our offices? This is not an exotic virus. It's not hard to kill. With the hospital grade detergents like hydrogen peroxide, ethanol, which is alcohol, even diluted bleach, which we can make at home, all of these things kill the virus, the SARS-CoV-2 virus, and many, many other viruses too. So it has that added bonus. Anything we buy now in the stores, so back in March and April, things were on shortage, but now you can find these products very readily. So Lysol, Clorox products, really anything you pick up in the store, if you look on the back, will have the EPA registered number, and it'll say it's effective at killing respiratory viruses. So you can't go wrong with any of these products. Okay. Hang on, I'm sorry. Okay. Is it safe to ride the subway? So I would argue yes. I get a lot of questions about this, but I actually think it's very safe. My husband takes the subway every single day, both ways. I sometimes take it. I work a little further, so sometimes I drive. But here's why subways are safe in New York City, and here's why buses are safe. Every day in the twilight hours, they shut down for deep cleaning that you can see this gentleman doing here. He's spraying hydrogen peroxide, and they do a very high level of disinfection. There's also HVAC systems in subways, and the HVAC systems, basically what they do is they circulate the air, but it's new air. It's from the outside in. And so that makes it so it's not the same air that people are breathing continuously. The other thing about buses and subways, which I love, is that every 5 minutes or so, there's a stop and the doors open to the outside and brings in all this air in, and people are leaving and new people are coming on, but it's not necessarily the same exposure all the time. What I tell my colleagues and my students is, you're essential workers. You need to take the subway, you need to go to your job, and it's safe to do so. Here's how you make it even safer. On the subway platform, stand 6 feet away from the next guy. In the train, wait for a car that's relatively empty so you can stand 6 feet away from the next guy. Have your mask on the entire time. Carry a bottle of sanitizer or wipes. And if it gets really tight in there, if you can't necessarily separate from the next person by 6 feet, well, that's where you take your, your free newspaper that you get as you're going down the subway stairs. You grab that guy, you open it up in front of your face, and it's like a shield almost between you and the next person. And subways have really not lately, since the mask rules and the mask mandates, subways and buses have not been linked with major outbreaks of COVID-19 in New York City. That's really not where this is coming from right now. Okay, so let's talk about some things that are floated frequently as far as do any of these supplements and vitamins and other simple measures, do they actually prevent or fight the disease in any way? So there's a lot of talk about things like zinc and vitamin C for respiratory viruses. Turns out there's not a whole lot of data behind these in actually preventing the virus or cutting short somebody's illness. But what I tell people is, while they're not going to take away the COVID, while they're not going to necessarily give you more protection that a mask, it's never going to be as good as a mask. But you know what? Why not? It's certainly not harmful. If people want to take this and they're doing it along with all the other things we talked about, the masks and the social distance, and it's part of a package deal, then go ahead. It's not causing harm, in my opinion. These saline nasal washes, I'm less a fan of those, because those devices themselves, they can harbor bacteria and viruses if you're not diligent about cleaning them. And so you may actually be causing more harm than good. So I actually really don't like these. I've never recommended them to anyone for any purpose. Okay, let's talk a little bit about blood type. There was a question posed about the science behind blood types and either getting the virus or the risk of severe outcomes from the virus. So there was this huge study out of New York City, actually, at NewYork-Presbyterian, in which the researchers found a couple of associations between blood type and then risk of disease. So I'll just quote the paper here. They're saying, we find slightly increased infection prevalence among non-O blood types. So what this means is that people with non-O blood types may have a higher, they may get the disease more frequently than O blood types. We don't really understand why right now, but it seems to be an observation that different scientists are picking up on. Risk of intubation, or let's say critical illness and people requiring the breathing tube because their lungs have failed, was less among people with A blood types, but more among A, B, and B blood types compared with O. So it's interesting, there's a couple of findings with these different blood groups. And then finally, the risk of death was increased for type A, B, and decreased for types A and B. Okay, so there's definitely some data to say that different blood groups, blood types, and different antigens on red blood cells may have different associations with COVID disease and also risk of bad outcomes. Okay, let's talk for a second about blood transfusion. Sorry, I'm just going to take a second to plug in my computer so it doesn't die. Okay, sorry about that. Okay, so what about blood transfusion? Is it safe to receive blood products right now? Is it safe to donate blood products right now? Blood centers take lots of precautions, just like all other medical types of facilities, in that there's an extensive screening process where they will ask donors what their medical history is, where they've traveled. They probably do some kind of entry screening like temperature checks and a huge checklist of questions. And so with those standard screening processes, blood donation is considered safe to both the recipients and the donors, okay? What we know about blood transfusion and COVID right now is that no studies have established that people are becoming infected by means of blood transfusion, okay? Far more likely they're becoming infected by people coughing on them than receiving a blood product. So bottom line is that blood donation and receiving blood transfusion is considered to be safe, and there's no evidence to counter that. Okay, what about reinfection? So depending on which part of the country you might live, if you were part of that initial phase of COVID in the United States, so places like Seattle, upper Northwest, Northeast, we're starting to hear cases of patients getting similar illness as to what they got back in the spring. And it's not entirely clear if this is due to a brand new strain of the virus that has a different genetic footprint than the original virus from the spring, or if this is just a weird aspect of how COVID-19 works. We know that there's a lot still we don't understand, but we've seen several people, actually up to 20% of people who originally had COVID still have persistent lingering symptoms, and they're never quite 100% for a long, long time, for many months after their initial infection. So there have been a handful of reports of people having confirmed reinfection in that the genetic sequence of the original virus is different than the genetic sequence of their next episode of infection. But outside of a very small handful of cases, we've not been able to prove this. More than likely, most people who have some lingering symptoms or who may test positive again, that's the same old original virus that may be still present in somebody's system, but dead particles or non-infectious particles. Okay, let's talk about travel. Travel right now, the latest recommendation as of this week from the CDC is they're strongly discouraging holiday travel. This is because of how exponentially high the cases are rising. And so my recommendation as well would be to seriously rethink travel. And if you must travel because there's just a reason you absolutely have to travel, you should definitely get tested before and after, wear a mask throughout your time there, and do all the things we talked about. Okay. So just in the interest of time, schools are now kind of closed in lots of places. They're all remote, but schools have not really been linked to major outbreaks since the fall. And this is because they're highly controlled settings where kids are far apart and everyone's masked all day long. What I don't like, though, is we have little control of what families do on weekends, where they're going, who they're going meeting with. And so this is where it becomes very difficult to control. Okay. And so just to finish up, here are my personal takes on COVID and prevention of COVID and safety measures. And this is really from having dealt with this disease as a provider for the past many months. The number one thing that you can do, if you had a choice to pick one of those things, it's the mask wearing. Again, nose, mouth, all the time when you're in public and you're going to any uncontrolled setting where you really don't know what other people are doing. Of course, hand hygiene and distancing are important, but if you only did those without the mask, you're still going to get COVID. What's driving the serious growth of cases right now is indoor activities. Eating, drinking together, not wearing masks, large gatherings, parties, weddings, all these no-nos. what should you do right now? We're gonna recommend that people don't do these things and don't do other leisure things like travel, but here's what you can still do. When you take all the precautions, you can go to the grocery store, you can go to the pharmacy, you can go to work, you can go to school if it's still open, and please do go to your medical checkups, okay? All of these settings are highly controlled and people are taking the maximum precautions to protect you. So these are essential activities and you should continue to do them unless instructed not to do so by your medical provider, okay? So with that, that's the end of my presentation, and I'm happy to stay around for questions later on.
Great, thank you so much, Dr. Nori. That was excellent. I would now like to introduce our next presenter, Dr. Sujit Sheth, who will talk about COVID-19 as it relates to thalassemia. Dr. Sheth is the chief of the Division of Pediatric Hematology Oncology and professor of clinical pediatrics at Weill Cornell Medicine and an attending pediatrician at NewYork-Presbyterian, Phyllis and David Komansky Children's Hospital, and Weill Cornell Medical Center. He is also vice chair of clinical research in the Department of Pediatrics at Weill Cornell Medicine, and Dr. Sheth directs the New York Comprehensive Thalassemia Center. Dr. Sheth.
So thank you very much, Craig, for that lovely introduction, very kind. And thank you for the invitation. And I also want to thank the Cooley's Anemia Foundation for setting this up because it's very informational. And for all of the other activities that the Cooley's Anemia Foundation does for patients and families with thalassemia as well. We don't have that much time, so I'm going to go fairly quickly. I don't have slides. But I'm going to answer some of the questions that Craig had sent me that all of you have submitted to him. But first, what I wanted to do was to just give you an idea about our own experience with COVID-19 at Weill Cornell in our thalassemia program. So we had 4 patients who actually developed symptomatic COVID-19, and one of them was pregnant. And all 4 of them did fine. They had, one only had a loss of her sense of taste and smell, nothing else, no other symptoms at all. The pregnant lady, as well as the other 2, also had mild respiratory symptoms, mild fever for 1 or 2 days, and a little bit of stuffiness and congestion, and one patient had a light cough, but nothing heavier than that. And we advised them to just make sure that they stay well hydrated, and if anything should change, and Dr. Nori mentioned some of the things to worry about, and none of them developed any of those in terms of the blue lips or the chest pain or the respiratory distress. And so they all recovered without any specific intervention. They did not need to get remdesivir or steroids or anything like that. But those are, of course, usually administered to people that are admitted to the hospital. We also have had 3 other individuals who we tested because they asked to be tested for COVID-19 antibodies, and they turned out to be positive. These individuals do not recall any symptoms whatsoever, no fever, no stuffiness, no sore throat, nothing. So they obviously had a completely asymptomatic infection at some point, and now have antibodies to COVID-19, to the SARS-CoV-2. So that's been our experience. And as far as I can tell, there's one publication from Italy that talks about approximately 12 patients in Italy. This was early on with thalassemia who developed COVID-19, but none of them developed severe disease. I think a couple of patients were admitted for a very short period of time, but all of them survived and recovered very well. There is an ongoing registry for thalassemia patients with COVID-19, and as far as I can tell, nobody has succumbed to the disease. Nobody has had severe complications as of yet. So I'm just going to go through the questions that Craig sent me. So the first question is, I've changed the order a little bit. The first question is, are there differences between transfusion-dependent individuals and non-transfusion-dependent individuals in terms of a higher risk of being infected or getting a more severe case? And so what I will say here is that the difference between transfusion-dependent patients and non-transfusion-dependent patients is just what kinds of pre-existing complications or complications they may have. In the transfusion-dependent patients, it's mostly related to iron overload. In the non-transfusion-dependent patients, it may be related to a vascular involvement. So your blood vessels may be involved with just by the thalassemia itself, not necessarily related to COVID. And you might have things like ulcers and the likes, or developing pulmonary hypertension or things like that. So in that sense, from what Dr. Nori talked about, the propensity for developing blood clots, individuals with non-transfusion dependent thalassemia, given that they may have some vascular disease, may actually be at a higher risk of developing blood clots related to COVID-19. Other than that, there are no real differences, and we'll talk about splenectomy next, but other than that, there really aren't many differences between the two. So iron overload does depress your immune system, and so that might be something that also contributes to the development of more severe disease. Again, we don't have all of the data from the patients that we know who had COVID-19 in terms of whether they had severe iron overload or whether it was well controlled. So that's something that we will look at in the future and see whether or not this is something that, with very small numbers, it's very hard to really tell whether or not that is something that happens. So we don't think that, unless your immune system is actually compromised and unless you've had other things related to your immune system being compromised, we don't think that in general, the iron overload makes you more susceptible to either developing COVID-19 or to have more severe complications related to COVID-19. The caveat here is that if you have COVID-19 related, if you have iron overload related heart disease, or you've developed lung disease, for instance, if somebody's developed pulmonary hypertension, then those are independent risk factors, independent of thalassemia. The thalassemia may have caused them, but those are independent risk factors that do make you more prone to developing severe COVID-19 disease. So those are things that you have to keep in mind. Just like if you had iron overload related diabetes, we know that diabetes is a risk factor for developing more severe COVID-19 disease, right? So whether or not your diabetes was as a result of iron overload or not, that doesn't really make a difference. If you have diabetes, you are at higher risk. So keep in mind that those risk factors that Dr. Nori so thoroughly discussed, those are risk factors for anybody. And whether it's the thalassemia that's causing those risk factors like heart disease or lung disease or kidney disease, or whether it's not related to thalassemia, those still remain risk factors. So if you have thalassemia and you have those, then yes, you are at risk for developing those complications from COVID-19 as well. Specifically related to the splenectomy alone, no, I don't think that, so we know that your spleen is really relevant in terms of your immune function for bacterial infections, particularly those encapsulated bacteria like pneumococcus, the bacteria that causes pneumonia and things like that. So those you are more prone to getting, but viruses, not so much. So we know that if you have had your spleen taken out, you could get the flu just like anybody else, and you're not at higher risk of having worse disease from the flu or any other viral infection. And so the same thing applies here as well. We haven't had any indication that not having your spleen, just not having a spleen, no other relevant immune dysfunction, but not having your spleen alone, that makes you or puts you at higher risk of getting COVID-19 or having more severe complications of COVID-19. The next question was, does iron chelation and COVID-19, do they have a role to play? So what we still recommend is if you have a fever, you hold your chelation. That's standard of care. And you all know that if you have a fever, you should not take your iron chelation for at least a couple of days after the fever has completely resolved. And the same thing applies here, because when you have a fever, you don't know whether it's related to a viral infection or a bacterial infection. And if it is a bacterial infection, then the fact that you don't have your spleen does make you more prone to developing a complication. Now, why do we stop the ion chelation? We stop the ion chelation because the chelator actually brings iron out of stores where it is well sequestered. It's nicely packaged inside those cells, and it's not exposed to the bacteria that may be circulating. All bacteria require iron to thrive and to multiply, and therefore bringing more iron into the system outside of those normally secure storage sites does make it worse if you have a bacterial infection. So we do recommend to stop the ion chelation, irrespective of whether the fever is known to be as a result of a viral infection or not. Still, hold the chelation if you have a fever, at least for a couple of days after the fever has completely resolved. And so, to summarize, the question being, are patients with thalassemia more susceptible to severe cases or complications of COVID-19? The answer is, so far, we have not seen that. However, there are risk factors that patients with thalassemia have, both non-transfusion dependent patients who may have vascular disease, as well as transfusion dependent patients who may have iron overload. And all of those could cause either cardiac disease or pulmonary disease or diabetes. And therefore, those are risk factors in thalassemia patients for sure. In addition to that, all of the other things that Dr. Nori mentioned, obesity, smoking, vaping, all of those things are independent risk factors as well. And so if you already have one or other risk factor, try and mitigate those as far as you can by staying fit and active, not gaining weight, and certainly not smoking or vaping of any kind whatsoever. The next question is, what precautions should I or my healthcare facility make to help decrease my chances of acquiring COVID-19 when I go for a transfusion? And here again, I will echo what Dr. Nori said: masks, 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 and social distancing as much as possible. And I think most healthcare facilities are checking patients when they come in terms of, do they have a fever, do they have other symptomatology. You invariably will get a call before your appointment to check whether you have any of the symptoms that put you at high risk for possibly having COVID-19. And so those are things that that you should be careful to answer very correctly and honestly, not only for your own sake, but for others as well who you might be coming in contact with at the healthcare facility. So other than that, no, I think if you stay well hydrated, you can, your nutrition should be good, stop smoking, doing all of those things. And then when you're going to your healthcare facility, make sure to check off all those boxes to make sure that you're not at high risk. And of course, keep your mask on and try and stay as far away from individuals as possible so that you don't have a higher risk of being exposed to somebody who might be coughing or something like that. So other than that, I don't think there's anything else special that I could recommend for somebody with thalassemia to prevent getting COVID-19. As far as supplements and things like that, Dr. Nori has already mentioned those, and I don't have any different opinion on those. We don't really have ways of boosting the immune system that are well documented and well understood. So, things that don't have any harm, sure, you can go ahead and take vitamin C. I don't see there's any problem with that. But other than that, I would not take anything as a preventative. For instance, taking hydroxychloroquine or other things that have been in the media. I would strongly recommend against doing any of those things as well. There was a question about whether patients at different age groups need to practice any different safety precautions. And so we know that children in general are less at risk of developing severe COVID-19 disease. They may catch it, but they may be more likely to be asymptomatic than adults. And again, the same thing applies in terms of older individuals being at higher risk, as well as individuals who have those other complications, cardiac disease, pulmonary disease, diabetes, etc. So I think that those are the things that that you need to practice. I don't think there's any different precautions based on age. I think universal precautions should apply here. And then the final question was, is the pandemic causing interruptions in clinical trials for thalassemia? And the answer is yes, to some degree. For a period of time, we were not able to enroll any new individuals for the clinical trials because we were trying to minimize the number of visits that these individuals made to the hospital. So if they didn't need to come in, we wanted them to stay away. If they did need to come in for their transfusion, that's fine. So anything that was a clinical trial that could be done when patients came just for their transfusion visits, those continued, but everything else was interrupted. We were just getting restarted, and so far we have not had any directive to stop the clinical trials again. But if the cases continue to go up and the proportion of people getting who are positive continue to go up, then we might have to do that again. So we have restarted those clinical trials, but it's possible that they may be interrupted again. And so that's basically it. I think that the biggest thing I want to stress here is that the risk that thalassemia patients have from COVID-19 is, as I've mentioned, mostly in individuals who have pre-existing morbidities, the list that Dr. Nori showed you. The other thing I really want to stress is that there is a possibility that the blood supply could be interrupted. This is because all of those blood drives and things that the various blood centers were carrying out, especially at college campuses and things like that, those have all been halted. And so we are now dependent on patients, on individuals, donors, going regularly to donate blood. That maintains the blood supply. And if the blood supply is not maintained, then individuals with thalassemia transfusions may actually have to be either delayed, stretched out a little bit further. You might have to tolerate lower hemoglobins. So far that hasn't happened, and we hope that it doesn't happen in the future either, but it is a possibility. So the one thing that I'm going to say here is I'm going to encourage family members and friends, please talk to your friends, talk to your family members, ask them to go and donate blood, because it may actually help you. It may actually be really important that the blood supply be maintained so that you can continue to get your blood at the regular interval that you're getting it in the normal amounts that you're getting, 1 unit or 2 units or whatever. So please, that's a pitch that I'm making to please ask friends and family to go and donate blood. It's a very noble cause, and it will help not only you but many others as well, with thalassemia or without. So with that, I'm going to stop now because it is the top of the hour, and see if there are any other questions.
Great. Thank you, Dr. Sheth. Excellent, and thank you for bringing up the importance of blood donations. We're going to quickly run through the questions that we asked earlier and ask you to answer them again, those of you watching one more time, and then we'll try to get to a couple of questions before we have to go. So if we can go to the next question in the poll. Again, you've answered this before. Please answer it now. See if your answer is different from when we asked this at the beginning. And we'll just take a few seconds here. About 5 more seconds. Okay. And rather than go to results, let's just go to the next question now. Okay, what's the most effective personal health measure that can be taken to prevent COVID-19? Again, you answered this earlier. Answer it again and see if your answer has changed. About 5 more seconds on this one. Okay, next question, please. Which of the following is true about COVID-19 and thalassemia? And just a few more seconds to put in your answer. Okay, and next question, please. Individuals who get blood transfusions are at higher risk for COVID-19 because it is transmitted through blood, true or false? Just a couple of more seconds to enter this one. Okay, next question, please. It is okay to travel this holiday season, true or false? Just a couple more seconds. Okay, and let's close that, and Cheyenne will skip the last question. We won't ask that one after all. So we'll quickly, we've only got a couple of minutes, but we'll try to get to a few of your questions. One of them, Dr. Sheth, we had a patient who wanted to ask, should you still get transfused if you test positive for COVID?
So, well, if you need to get your transfusion, yes, but if you test positive for COVID, you should not be going near the hospital, because you have in the hospital, particularly in your infusion centers, you have patients there who have higher risk factors for getting more severe COVID. So until you recover from your COVID and until you are negative, you have to follow the protocol that the infusion center has in terms of whether you can go there or not. There are some infusion centers that do have a specific COVID positive unit where you can go if you are COVID-19 positive and get your transfusion. So for instance, at Cornell, we do have that. We have a specific unit where we had those patients who were COVID-19 positive who needed their regular transfusions. They were able to come there and get their transfusion. There's a very elaborate system where they are met on the street and brought in with, specific precautions are taken. They're masked and all of those things are put on, and they're brought into that unit, and then they're escorted out as well. So if you need to get it, you need to get it, and you have to find a safe unit that is able to give it to you. But otherwise, if it's okay to delay it until such time as you're able to go in based on the protocol for those units, then you should delay it.
Thank you. We have a couple of questions about a vaccine, which we know is theoretical at this point. So, but I'll ask them both first. The first one, Dr. Sheth, is for you. Basically, it's asking, once a vaccine becomes available, do you recommend that thalassemia patients get it? And if so, is there any basis on whether their age or their diagnosis comes into play? And then Dr. Nori, for you to be thinking about while Dr. Sheth is answering, in terms of mRNA vaccines, is that going to have any potential effect on the blood supply in terms of, will the antibodies used in the vaccine get transmitted into the blood supply if somebody gets the vaccine? So Dr. Sheth?
So I'm going to say yes. I'm going to say, these vaccines are going to be, they've gone through pretty rigorous clinical trials. I don't think Pfizer wants to stake their reputation on doing a poor clinical trial and putting out a vaccine that is not going to be effective or safe, right? It's a company that's been around for 100 years. They don't want to completely blow themselves up by putting something else like that out. The FDA is going to be responsible. They're not going to allow something to come out there that is not either effective or safe. So yes, I know that we will be the first ones, the healthcare providers will be the first ones to be getting the vaccine once it comes out, and I'm absolutely going to take it. So I would recommend that, yes, unless there's a specific contraindication for you to not take it, I would recommend yes, taking it.
Thank you. And Dr. Nori?
Sure. So I will echo that exactly, which is that I am planning to take that. My husband is planning to take it, and as soon as it's available to my age 65 plus parents and in-laws, I'm going to make them take it as well. The question about the antibodies then becoming a part of the donated plasma or blood, that's an excellent question, and there's a high likelihood that it will be part of the blood product. It just may not be enriched in a way that it counts as far as a secondary, what we call immunoprophylaxis. So convalescent plasma and monoclonal antibodies are sort of a similar concept in that you're taking a surviving patients or a bunch of them, you're taking their plasma where all the antibodies live against COVID-19, against the virus, SARS-2, and you're giving it to someone who's suffering from the illness. And so though that's passive immunity, that's going to last only so long. And it's going to do maybe some good, but it's not, it hasn't been the therapeutic bullet that we were hoping for. And so it's not going to be a swap out for getting the vaccine.
And if you're
just to add to that 1 second, the amount of plasma that you get with a blood transfusion is really small. It's about 15 mLs of plasma, and to get enough antibodies in 15 mLs of plasma, it's just not going to happen. So you're not going to get enough immunity from blood transfusions because the amount of antibody that you'll get that way is very, very small. The other thing is whether or not you will test positive for the antibody just because you've gotten a blood transfusion. Now the tests are very, very sensitive, but they still have some threshold. So if you get 15 mLs of plasma for somebody who had COVID-19, chances that you will be antibody positive or you will stay antibody positive are quite small, because it's not going to last very long, and the amount that you got is going to be diluted in your entire body. So you're going to have very, very, very low titers, if at all.
Great, thank you. And I'm so sorry because I wish we could spend another hour on this. We do have the questions that everyone submitted, and we'll do our best to answer them outside of this webinar. So thank you all for your questions. And thank you so much, Dr. Nori and Dr. Sheth, for all the valuable information and for joining us today. I can't thank you enough. It's been wonderful. Everyone that's on the call today, you'll be receiving an email asking for your feedback. You'll also receive a link to a recording of the webinar, so you'll be able to re-review it as much as you would like to. And if you have any questions, you can contact me at cbutler@thalassemia.org. Finally, just a plug for an upcoming event. On January 8th and 9th, the UCSF Center for Maternal Fetal Precision Medicine is organizing an international virtual conference for alpha thalassemia major. The conference will bring together patients, families, and providers from around the world to consider current prenatal and postnatal treatment for alpha thalassemia major. In collaboration with us, CAF, and the Thalassemia International Federation, they will hold a special forum dedicated to building a patient group for alpha thalassemia major. Registration is free and all are welcome, and the link is in the slide that you see there. And finally, thank you all for joining us, and have a very great day, a lovely weekend, and a happy Thanksgiving. Thank you.
Thank you.